Are there any other regimens in elderly patients before we move on to the younger patient? Some people have used cyclophosphamide in this situation, or is there anybody you wouldn't give lenalidomide or Velcade to, bortezomib to?
I think that the real question is going to be, when you use the Lendex platform with an antibody, does that sort of give you a longer PFS and OS that may eliminate the need for adding proteasome?
I promise I'm going to come to the new drugs, but cyclophosphamide, anybody using that in elderly patients?
I think there are some roles for cyclophosphamide still. So for example, renal failure, somebody with poor performance status, so you're worried about a thrombotic risk with an IMiD, somebody who's potentially inpatient
can't
or
take anticoagulants maybe.
Yeah, exactly. So and it doesn't mean that you could also, sometimes people feel like it's either or, and it doesn't have to be. You could start with bortezomib, cyclophosphamide, dex, and then when some of those concerns have improved,
then
switch to
I think that's very, very well said. The only other point I'd make, Keith, is that really building on Sagar's work, we are also very comfortable in our maintenance strategies with higher risk older patients, offering bortezomib every couple of weeks subcutaneously, because we do think that in those patients, particularly with adverse cytogenetics, that there may be benefit to that approach, particularly if it's well tolerated.
And so for this older patient, does it matter to you if their genetics are high risk or low risk, or is just everybody going to get VRD, and maybe any change in therapy, any point in measuring it?
So I think with the community side, I think there is a risk. There is a role for bortezomib-based therapy for high-risk patients. So I think that we need, and I think the other important thing coming back to the cytoxin is a different issue with the fact of cost. And so this a good, cheap drug, and it's effective. And so I think we have to keep that in mind as well for patients.
Particularly to Ajay's point,
I guess the flip side of that is there is data being presented at the meeting where VTD is superior to VCD. And we've certainly, and again, it's anecdotal data. I know you probably have the world's largest collection of VCD, but the cyclo in the context of high-risk disease is not a benign thing.
I agree, not in high risk, but...
So
my only comment about that paper is, well, we'll get to that later, but it depends. The devil's in the details of how you give the drugs. But, so you've been dying to get to the new drugs. Tell us all about what's exciting and what's coming. What do you see? Obviously, none of these drugs are approved in the frontline setting yet. We're going to talk a lot about them in relapse, but just very briefly, what do you think is going to change? We're talking elderly patients still. What gets you excited about the new drugs? You started, Paul.
Well, if I may, I think that the availability of ixazomib up front as an oral weekly drug, as a well-tolerated proteasome inhibitor.
Just to be clear, it's not available yet.
Not yet. It's in the relapse setting, but I mean, that will be coming because we will have the results, hopefully, from tourmaline that support its use up front. But it's a well-tolerated drug, once a week, part of an all-oral regimen. Complements lenalidomide-based therapy, in my experience, very well. I think that will be a major advance for older, frailer patients. It simply doesn't have the neurotoxicity of bortezomib. The cutaneous issues with it are relevant but very manageable. It has minimal GI toxicity once you get very comfortable with its use. And it doesn't also have some of the more rare but worrisome side effects that we sometimes see with carfilzomib, namely the cardiovascular, vascular thrombotic risk. That's not seemingly the case. So for older patients, this I think would be an excellent proteasome inhibitor in the future.
I'm going to guess what you're going to say, but go ahead and say it.
I think it's the antibodies. The antibodies are, especially
anyone in particular?
Well, I think there's certainly encouraging data with both ELO and DARA in the newly diagnosed myeloma setting in combination with lenalidomide. I think the question is, for the truly frail patient, is it going to be an antibody IMiD or is it going to be a proteasome inhibitor IMiD? And I don't know the answer to that. But the antibodies are just so well tolerated, and that I think
but require intravenous delivery every week or two, so not.
It depends on where you are in therapy. In the beginning, more frequent visits, but once you get beyond that, the frequency does drop off.
I think to expound on that a little bit, the two patient groups that are probably bringing down the median overall survival for myeloma now, because we've made a lot of strides, are elderly and high risk. And those are populations where these monoclonals should do really well because excellent tolerance and they're genomically agnostic, So I think we have a real exciting future with improving our median overall survival for all patients.
Yeah, but to the point of clonal heterogeneity and to the point of what I love the way Sagar's framed this, you've got plasma cell biology that you drive with inhibiting protein degradation and the immunomodulatory effects of our IMiDs, I do think it's not necessarily going to be a zero-sum game. I think what we're going to have is an immunomodulator, a proteasome inhibitor that's well tolerated, and an antibody as our sort of main frame going forward. And I think that will provide us with really dramatic duration and duration of clinical benefit that will be transformative, I hope.
Okay, so what I think we heard for the elderly patient is if they're, that most people are framing lenalidomide, bortezomib, dexamethasone at attenuated doses as the therapy of choice, perhaps lenalidomide, dexamethasone for people who are very frail alone. For those who can't take lenalidomide, dexamethasone, perhaps a cyclophosphamide, bortezomib combination. And the future is obviously oral proteasome inhibitors and antibodies. I want to move on.